Hi, my name is Todd Baron, and I'm the Director of Advanced Therapeutic Endoscopy at the University of North Carolina in Chapel Hill. And I'm here to do an author interview for our article, EUS-guided transhepatic biliary drainage, a large single center US experience. So we decided that it was important to publish our data of EUS-guided transhepatic biliary drainage. We began performing at University of North Carolina EUS-guided biliary drainage through the liver in 2014, and our experience in this series included 215 patients. The main reason we thought that it was important to publish this is because most of the series, if not all the series, on EUS-guided transhepatic biliary drainage, which have mostly been or predominantly been EUS-guided hepatogastrostomy, have come from outside of the United States. These have been published in gastrointestinal endoscopy with editorials suggesting that the tools are not available and the stents are not available to perform such drainage procedures in the United States. So again, we thought it was important to demonstrate that given the tools that are available inside the United States, which include commercially available devices, fine needle aspiration needles as access punctures, guide wires, and fully covered self-expandable metal stents that are commercially available, would be welcome to be seen by the readers of gastrointestinal endoscopy. We also felt that it's important to introduce a relatively new nomenclature. We've known for many years of percutaneous transhepatic biliary drainage, which is known as PTBD. And because our entry sites of puncture have been through the right and the left lobe, but also through the esophagus, stomach, of course, but duodenum, and in post-surgical anatomy cases through the jejunum, that the better or more appropriate term would be similar to PTBD, and that is EUS-guided transhepatic biliary drainage, or ETBD. And we had not found this to be present in the literature as a nomenclature. And again, we feel this is appropriate because of the many access points through the liver. So we published the results of our series that included benign and malignant indications. Many of the cases, nearly 50%, were in patients who had surgically altered anatomy. And that's one of the reasons that we began doing transhepatic biliary drainage rather than choledochoduodenostomy, is because we were seeing a large number of patients with surgically altered anatomy where you cannot access a duodenum, or duodenum is not even present to allow you to do an EUS-guided choledochoduodenostomy. So again, ours were EUS-guided transhepatic biliary drainages through a variety of puncture sites. In patients with benign disease, the goal was to resolve the benign disease completely by using the EUS-guided approach to the liver as a portal of entry to allow additional downstream endoscopic therapy. So for example, we had many cases of patients who had hepatico-jejunostomies done for a variety of reasons, often patients who had had gallbladder operations that were complicated by bile duct transections, and then the anastomosis of the hepatico-jejunostomy became stenosed. So rather than perform long limb procedures where you take endoscopes and try to reach through the retrograde approach, which is somewhat problematic in terms of long length scopes and limited devices, we felt we could puncture from above, create the transhepatic biliary route, and then perform downstream therapy for resolving anastomotic strictures, or in some cases in patients who had intact biliary trees, for example, in the setting of room-wide gastric bypass. We could resolve choledochal lithiasis by balloon dilation of the papilla and then passing stones in an antegrade fashion. Ultimately, the goal is to resolve the benign disease and to remove the transhepatic biliary drainage to allow the entry point to close. For patients with malignant disease, again, many of these patients were post-surgical anatomy, or they were patients that had duodenal obstruction that prevented us from performing traditional retrograde therapy. In these cases, the transhepatic stents would remain in place either indefinitely, or in some cases, we use them as preoperative drainage pathways, and it would not interfere with Whipple operations. In other cases of malignant disease, it's important to note that, for example, with hilar, complex hilar cases, in some cases you cannot access or drain certain segments either from the right or left in a retrograde fashion, and therefore we proceeded to drain these areas through, again, the liver, whether it be through the duodenum to get to the right lobe, or from the jejunum into the right or left lobe, and again, through the stomach or through the esophagus into the left lobe. Again, we used conventional, commercially available, fully covered, self-expandable metal stents with anti-migration fins. Once they were placed, we did not experience migrations, for example, into the peritoneum or migrations outwardly with loss of access, which would lead to severe adverse events. We did have adverse events that were in keeping with other series of EUS-guided transhepatic drainage. The biggest, again, take-home message was the high rate of success in experienced hands. Our technical success was close to 96%. Clinical success was in the high 80%, and of course lower for patients with complex hilar biliary obstruction with advanced hilar, say, bismuth type 3 and 4 disease, where those patients don't always get the clinical response you're looking for because of the extent of the disease. So we feel confident that our results can be duplicated in US centers using the same techniques. There are a lot of nuances to EUS-guided transhepatic biliary drainage that we could not discuss in the paper. And so we believe that these sorts of procedures should not be undertaken by people that do not have, or endoscopists that do not have a vast experience in EUS-guided procedures and a combination of EUS-guided expertise as well as ERCP expertise, because really these procedures are combined procedures with EUS and ERCP skill levels. We hope that you find the discussion in the paper and the findings that we presented here germane to your practice, and perhaps if you're thinking about entering into EUS-guided drainage, that this will provide you with some impetus or motivation or even inspiration to proceed in this direction. And I thank you for your attention in this author interview.